The first speaker is all-comers trial, 5 years outcome from Dr. Noppon. He's an active young aortic surgeon from Chiang Mai University. Please.
Thank you, Chairman and Co-Chairman. Today I will present it. I try to cut it short and sweet. Today I would like to present the TAA in all of the descending aortic pathology, 5-year insight from the real world. This is data come from the all-comer trial of the funds. This is my disclosure. And as everyone knows that the ceiling loss is one of the first cause of the TAA lead intervention. As you see from the picture, year by year, the aorta getting bigger and bigger, and sometimes if we have a birthday appearance, the landing zone will be shorter and shorter, and one day it will cause the type 1A endoleak. As you see from this picture, this is the patient that start from the 2010, and then 9 years later, just only the small birthday appearance. In the end, it will be more and more. And for this case, even there is a very good landing zone, everything is still quite well. But 10 years later, the type 1A endoleak still can be occur. So the seal loss is the first for the TAA re-intervention. This data was confirmed by many paper. And can device selection impact the type 1 endoleak? Yes, I think because the seal depend on two main factors. One is deployment accuracy, and the other is apposition of the stent graft. If we achieve the very accurate deployment, the seal zone can be achieved. And if there is any bird peak appearance, it will increase the risk of the type 1A endoleak around 8%. And for the Medtronic variant, cTBAD, the deployment accuracy is quite well because we have a tip capture. And it can deploy 100% success. And for the conformability and the apposition, this is why the proximal part have the best stent and also have a mini supporting spring that can achieve even the graft that can remain apposed through 140%. Just only one graft that can achieve that. And from the VALOR 2 trial, there is a 0% type 1 endoleak at 5 years. And how about in the real world? This data is come from France. This is a non-randomized control trial study, and the primary endpoint is all-cause mortality at 5 years. And as you see that they include the 160 subjects that enrolled from the 2013 to 2015. Most of the cases TAA and the PAU, and the second cause is a dissection. The third is one traumatic aortic injury, and the others. I will focus only in the 4 main etiology. You can see that the TAA is the most common cause. Number is 62, emergency only around 16%, and the patient is quite old. In the PAU, the emergency treatment is around 28%, and you can see that the patient is getting older and older. But for the dissection, emergency is 27%, but the patient is younger, and the BTI is for sure the emergency is 100%, but the patient is pretty young. As you see that TAA, you can see the proximal landing zone is mostly confined around the zone 3. And from the data at 5 years, they can achieve the freedom from related TAA-related mortality nearly 98%. And the freedom from the secondary re-intervention nearly 80%. For the PAU, the landing zone is moved a little bit to zone 2, and the freedom from PAU-related mortality is still high, 94%, and the freedom from secondary re-intervention is around 66%. However, there is some endoleak for sure. There is a 12 type 1 endoleak, 7 for type 1A, and 5 for type 1B. But only 6 cases have to treat. 6 cases can live untreated, and it can resolve. One case will have a type 3A, and there is no type 3B endoleak. For the dissection, the landing zone is mostly confined around zone 2. As you see that they can achieve the freedom from the aortic-related mortality 94%, but freedom from the secondary intervention is just only about 50%. It is quite common for the dissection. And about the aortic remodeling, you can see that at the baseline, 43.2%, the patient has a false lumen extended beyond the aortic bifurcation. And at the 5th year, they can achieve 100% complete or partial thrombosis of the stent graft region, and 78% that achieve the complete or the partial thrombosis. But if we focus just only on the complete thrombosis at the stent graft region, they can achieve 72% and 50% below the stent graft. For the BTAI, it's quite good for sure, and the landing zone is stay around zone 2 and zone 3. They can achieve the 100% freedom from the BTAI-related mortality, 93% from the freedom from the secondary procedure, and 96% for the all cause of the mortality. However, there is still some serious adverse event through the 5 years. There is no conversion, but there is a 3 aortic rupture within 5 years. 2 is at the thoracic part and can treat it with the endo. And just only 1 case that has the abdominal aortic aneurysm rupture that are related to the thoracic graft. There is 2 retrograde type A aortic dissection that occur only in the first 30 days. And one can treat it with an additional stent graft. One have to convert to open. And there is only 2 cases that has a spinal cord ischemia. And how about my experience in our institute? We are lucky that we start with Valiant Captivia nearly, I think, 15 years now. And from the picture, you can see that we started with BTAI. This case is maybe just the first few cases of our experience. From 2008 and right now is 2023, 15 years later, the Valiant Captivia is still approached with the aortic wall quite well, and there is no change at all about the anatomy. And this is the aortic dissection. This is also our very, very first case of the aortic dissection that we put the stent in. This is for this case is a chronic case. At that time, we still don't have a knowledge about the distal size, so we just only measure the proximal landing zone and then put the stent. You can see that there is a distal size here. But at the proximal landing zone, you can see that the stent is approached quite well through 15 years. And this is for the aneurysm. In this case, we perform the total debranching and then we put the TEVR. You can see that around 9 years, the stent is still approached to the aorta quite well without any change. So in conclusions, the seal loss is the first cause of the re-interventions post TEVR, and the deployment accuracy and the stent apposition are the TEVR decisive factor that impact of the seals. Valiant Captivia is uniquely addressed the seals. They had the best demonstration conformability and the high accuracy tip capture deployment. The front registry also confirm about that data through 5 years. Thank you.
Yes, sir. Jamrusit.
Yes, thank you very much for a nice talk. Can I ask you? You show nice results with Valiant Captivia in variety of diseases. About the acute dissection, the concern there are some concerns about the bad stent, the free flow, that may cause the retrograde type A dissection. What is your opinion about that?
In my idea, I think the problem about the proximal bad stent, the proximal bad stent occurred, the retrograde type A dissection is occurred very a lot during the first design of the stent graft. They know that if at that time they have a lot of the bad spring, but that a lot of bad spring cause a lot of pressure load on the ascending aorta too. So after that first design, they change to the variant captivia. They changed a little bit about the best spring. There has a less number of that, so the patient load is lower. And right now, the main purpose of that best spring is mainly for the alignment, not for the fixation at all. So I think in my experience, and in my practice only for me, I don't mind a lot about the bad spring. And if you see that right now, even from the Cook company, they end up with the bad spring. So I think right now we have more and more knowledge that the bad spring not make any not the only factor that caused the retrograde type aortic dissection. So in my practice, I don't mind about the bad spring even there is the dissection.
Thank you.
Okay, thank you, Dr. Noppon. So very nice presentations. Also, I suppose Professor Bong gave a very nice explain. Okay, thank you.